We're going to examine an arteriovenous fistula in a patient with end-stage renal disease. This is Mr. White, who has a fistula in his forearm, and we're going to perform a systematic physical examination. So physical examination of a fistula actually begins with the history of the fistula. So, Mr. White, when was this fistula created?
I see about a couple of years ago.
A couple of years ago. And have you had any problems with this fistula?
Yes, I have. I had it operated. It swelled up.
Okay, it swelled up,
and then
they had to go in and take care of it.
Right.
So he's already had perhaps treatment for a stenotic lesion. Physical examination should start with, after history of the patient, should start with inspection of the fistula. Inspection of the extremity and comparison to the other area provides a good comparison. On the fistula, one should see any aneurysmal dilatation or any bulbs, in simple words, in the track of the fistula. The palpation should begin at the anastomosis of the fistula. Mr. White's got a radiocephalic fistula, which has a very nice thrill at the anastomosis. Thrill at the anastomosis is predominantly systolic. Diastolic component is also there. Examination should also be performed with the 3 or 4 fingers instead of just one finger palpating the fistula. In addition, if you use the palm of your hand, this may be more sensitive and give you more information. So starting with the anastomosis, you move downstream in the direction of the elbow in this fistula. And Mr. White's got a continuous systolic and diastolic buzz, which we call thrill, throughout the inflow segment, body of the fistula, and the outflow tract of the fistula. The examination should not stop at the elbow. It should continue into the upper arm, into the axillary region, and also infraclavicular region in the central area in the chest. After you've performed palpation of the entire fistula from the anastomosis all the way to the chest, the examination begins with the evaluation of the inflow tract of the fistula. One simple thing is to check the thrill at the anastomosis. The other one is performing what we call augmentation of the test. With occlusion of the body of the fistula, this portion of the fistula should augment normally. This tells us that from the point of occlusion all the way to the anastomosis into the arterial system, the fistula is widely open. Upon occlusion, you should have only pulse. If you don't have pulse and you have if you have a thrill, this tells you that there is an accessory pathway, a side branch that is draining blood from the fistula, which could be problematic at times. Examination of the downstream stenosis involves palpation of the body and outflow of the fistula. If you have an outflow stenosis, you would not have a thrill. Predominantly there would be pulse. In this gentleman, we have a continuous buzz indicating that he does not have a downstream stenosis. In the event of a stenotic lesion in the upper arm area, the arm down here, forearm, would be swollen. And in the event of a stenotic lesion inside the chest, on physical examination you would see swollen extremity. In addition to the outflow and inflow stenosis, stenotic lesion could happen in the body of the fistula. And again, before the stenotic lesion, you'd have increased pulse, so the fistula would be hyperpulsatile prior to the stenotic lesion, and the thrill would be isolated systolic. The diastolic component of the thrill would disappear. This could easily be ascertain with the use of auscultation. By placing the stethoscope right at that area could indicate the presence of stenotic lesion. Mr. White doesn't seem to have that, although on skin one could see that there may be a stenotic lesion here. A quick physical examination can be performed in a matter of minutes. It could easily be performed in an outpatient unit or in your office. Simply raising the arm assesses the outflow stenosis. In the event of an outflow stenosis, the fistula would remain plump and would not flatten out. When there is no stenosis, the fistula should flatten out. This would indicate that there's no stenotic lesion from the anastomosis to the right atrium. On the other hand, occluding the fistula downstream and checking the inflow segment would indicate that there's whether there's stenotic lesion on the inflow or not. If the fistula augments well, then this indicates that there is no inflow stenosis. So two tests, arm elevation and an augmentation test, evaluate outflow and inflow stenosis respectively.